My name is Jenn Lichtman. I am an athletic training student at Manchester University, and I will be presenting on clinical prediction rules. Clinical prediction rules are rules that help guide clinicians in making decisions how to further treat a patient, whether that be by ordering further testing or coming up with a possible diagnosis. There are several steps that have to be taken in order to validate a clinical prediction rule. The first step is development, which is when researchers and clinicians find and identify predictors for a certain medical condition. The second type is validation, which is when researchers of clinical prediction rules put together a population to test the possible clinical prediction rule. Thirdly, impact analysis, which is essentially the results of the study. The impact analysis portion of developing a clinical prediction rule looks at the usefulness of the rule and how it could impact a patient. The final step for developing and validating a clinical prediction rule is implementation, which is when the CPR gets accepted in medical practices. There are numerous models that can be used to help validate and develop a clinical prediction rule. A scoring system, which gives a score based on the patient's symptoms and will help predict the likely outcome. A multivariate analysis, which uses logistic regressions, which is helpful because it shows relationships between predictive factors and the odd ratios. Nomograms, which are similar to the multivariate analysis. A nomogram uses a mathematical graph to look at relations. Neural rules, which is when the results of the study are put into software, which then interprets and gives an answer. Lastly, a cart analysis, which is a classification and regression trees which divides variables into subgroups and essentially makes a flowchart to help solve the answer. Clinical prediction rules can be beneficial in athletic training because it can help develop a course of action. Clinical prediction rules are set in place to help clinicians develop a plan of action in regards to treatment and further testing. Clinical prediction rules can also help speed up the process of evaluations. Lastly, ATC should use clinical prediction rules if other medical professionals are implementing CPRs into their medical facilities. Also, we need to be able to communicate in a professional manner with other medical personnel. The clinical prediction rule that I chose to research was on the development and validation of the Ontario Acute Myocardial Infarction Mortality Rate Prediction Rule. The Ontario Acute Myocardial Infarction Mortality Rate Prediction Rule looks at the mortality rate of an acute MI after 30 days and 1 year after the patient was discharged. The development of this particular clinical prediction rule came about because clinicians wanted to decrease the mortality rate after an acute MI. The study looked at reports from hospitals in Ontario and California to see what the mortality rates were after being discharged. The hospital in Canada looked at a total of 4,386 patient files, and the hospital in California looked at 112,234 patient files. Patients were excluded from the study if they were admitted originally for a non-cardiac event, non-surgical cardiac event, and transferred. After the exclusion criteria, there was a total of 56,616 patient files researched between California and Ontario. Researchers recorded what the initial mortality prediction was before 30 days or 30 days to 1 year following discharge. They then recorded the actual mortality, if any, for each patient. As previously mentioned, in order to validate a clinical prediction rule, one of the 5 models must be used in the study. The clinical prediction rule research model that this study used was a multivariate analysis because it used logistic regression to predict the 30-day mortality and the 1 year mortality rates at both hospitals. The impact analysis or the results of the study were positive. There was a significant correlation in the specificity or the observed mortality rates from the reports and sensitivity or the predicted mortality rates of the study. As the predicted mortality rates went up, so did the observed mortality rates, which gave a positive linear correlation, which is shown here as a correlation of 0.985. This shows that the Ontario Acute Myocardial Infarction Mortality Prediction Rule is validated and can be implemented and can be implemented into medical practices.